Dr. Gedwall, whenever you're ready, you can go ahead and fire away.
Awesome. I'll go ahead and start so I can go to sleep soon. All right, so starting off, as always, this information is confidential and it's privileged. It's protected by HIPAA, and that we should not be distributing it, copying it, or discussing it outside of this educational forum. Moving on to case one. This was a case that was referred by one of our medics. Thought it'd be a good, interesting case to discuss a little bit, as this patient has been using our system a couple of times for their condition. So this is a case of a 16-month-old who EMS was called for a seizure. Upon arrival, they found the patient in the arms of the mother. The patient was unresponsive. His airway was open, but he wasn't protecting it, and he was noted to be pink, hot to touch, dry. There was no signs of bleeding. Initial vital signs obtained were as follows: heart rate of 184, blood pressure of 128/93, respiratory rate of 60, and room air sats documented at 90% with a GCS of 3. The past medical history included seizure disorder, and the medications that this child was prescribed was Keppra with rescue midazolam. The history provided to EMS was that the patient had a history of seizures and that he has been seizing for 20 minutes despite receiving rectal Versed prior to their arrival, and that he had recently or is currently undergoing a illness with a fever. This occurred at 7:04 in the morning when EMS made initial patient contact. They noted that the child was having full body fasciculations identified as concerns for ongoing seizure, and that they also noted that the patient was in respiratory distress, noted abdominal retractions and inadequate respirations. They placed him on a non-rebreather, and because of ongoing seizures, they gave him 3 milligrams of IM Versed. I calculated based off of the patient's weight, it should be approximately 2.5 milligrams. I'm not really sure if that's difficult to administer, but a little bit higher than we would in our protocol recommend. And the patient was transported 6 minutes after patient contact. Because of ongoing seizure activity, another 6 minutes elapsed, and the patient was given another dose of 3 milligrams of IM Versed. There was only, unfortunately, one set of vital signs obtained, which are the ones that I mentioned to you guys earlier. Looking at what normal vital signs for this age, 16-month-old, he was known to be abnormal in almost, actually in all of them. He was tachycardic, greater than 160. His blood pressure was elevated for his age. His respiratory rate was significantly elevated above baseline, and his room air sat was 90%, and obviously his GCS was pretty low. They felt it felt that he was febrile, so they double checked that with a temperature monitor reading, which was 102.8, and at um, 10 minutes after transport initiation, he was given 240 milligrams of rectal Tylenol. They noted upon arrival to the hospital that his seizure activity had stopped. There was no Pulsera report that I could find for this patient, so I'm not sure if they used the HEAR. And then as for discussion of the pre-hospital care, I thought that this crew did a really fantastic job with rapid primary survey, getting a full set of vital signs, management of a seizure with a seizure history, as well as a suspected illness with a fever, initiation of transport to the hospital pretty early on. I believe it was like 6 minutes, if I remember correctly. Yeah. And management of his airway with BLS maneuvers. The two things that I think I would have liked to seen on this particular case is, despite the history of seizure disorder, getting a blood glucose, and then getting another set of vital signs, especially since the first set of vital signs were so abnormal, to see if our interventions were actually improving the patient in any ways, or if the patient was actually getting worse. Does anybody else have anything else to add? All right.
No, I would just say I suspect the vital signs is a documentation issue. I'm sure the patient is on the monitor and we're both following that, but it's, when we review the chart, it is helpful to pull in a couple of extra sets of vital signs. but I don't doubt that vital signs are being monitored.
Yeah, especially when they're this abnormal, we want to trend how the patient's doing, and especially in this particular case, when the patient arrived, the vital signs were actually worse than previously assessed. So he's still febrile, still pretty tachycardic, still a little hypertensive, and his original room air set was 83%. They noted that the child was pretty somnolent. They suspected postictal because he was responsive to pain, and it didn't appear that he was seizing anymore. Their physical exam was notable for tachypnea, coarse breath sounds, retractions, both intercostal and abdominal, with moderate respiratory distress. He was placed on high flow nasal cannula at 25 liters with a fractional inspiration oxygen of 30%. His labs were actually pretty normal. The only thing that came back abnormal was his viral panel, where he was positive for rhinovirus. And because of his underlying seizure disorder, he was given a dose of pyridoxine. His chest x-ray was obtained to evaluate his hypoxia to see if there might be a pneumonia or other process that might be contributing to his hypoxia. And they noted findings of inflammation consistent with viral bronchiolitis. And they noted that the patient did improve with the high flow nasal cannula, and because of his concern for status seizure and his hypoxia, he was transferred to Dornbecker's ICU. Once he arrived to Dornbecker, he was still on a nasal cannula, but was able to be titrated off pretty quickly. He was observed overnight. Trying to remember. The metabolic team for the PEDS hospital was consulted given his history of pyridoxine-related seizure disorder, and they recommended increasing his daily dose of pyridoxine in the setting of illness, and he was discharged the following day. So in reviewing this patient's chart, this was, I believe, his fourth presentation to our hospital at Peace Health, and he has been transferred all the times to Dornbecker. So this might be someone that you may have already seen or you may see in the future. So the paramedic that had taken care of this patient was intrigued by the fact that this wasn't a typical seizure disorder. It was kind of a pretty rare disorder, pyridoxine-dependent epilepsy. In reviewing the data on this condition, it's a seizure disorder that's not well controlled with anti-epileptic drugs, but can be responsive to vitamin B6 in a daily dose formulation. This is a autosomal recessive disease that manifests itself in two ways, both the classic and the atypical presentation. As for the typical presentation, the patients usually develop seizures within the first few weeks of life, in that these seizures tend to be prolonged and recurrent without any return to baseline mental status when they're untreated. The patients can have presentations that are anywhere from generalized tonic-clonic activity to atonic, to partial seizures, to infantile spasms, and to myoclonic seizure activity. But once these patients have been identified with this disorder and they're managed, they can be pretty well controlled, except for under like stressors like any kind of illness. Atypical presentations are, they usually occur later in the child's life, either late infancy up to 3 years old, and they are, I would say, not just a little bit, they're definitely more difficult to control, because the typical anti-epileptic drugs that we administer to these patients can have a response to seizure cessation, but the complicating factor is that initially these patients are not responsive to pyridoxine, and for whatever reason, in time they'll start to be responsive. So they're a little hard. These are patients that are harder to control, both by the fact that pyridoxine isn't initially effective and that we don't necessarily see a expected response with Versed or Ativan or Valium or even any of our other hospital administered anti-epileptic drugs. I don't actually know this kid's history if he's classic or atypical. I suspect that he's classic, but it wasn't delineated in his notes. And then treatment is going to be supportive, as well as daily dosing of pyridoxine, and then rescue, as well as daily formulations of anti-epileptics, depending on the pediatric team's recommendations. And then as for our protocol locally, I brought up seizures, specifically pediatric, given this is a 16-month-old, and that we'll move over to the right-hand side of the screen. So patients in status, recommend Versed 0.2 milligrams per kilogram that can be administered either IV, IO, intramuscular, or intranasal, repeated every 5 minutes until the seizure stops. And then we'll be really cognizant about the patient's respiratory status, both recognizing if it further declines, but also supporting it with BLS and potentially ALS maneuvers. If the patient's febrile with a temperature greater than 100.4, then and they're having a seizure, that you can also give antipyretics in the formulation of Tylenol or acetaminophen in a suppository, with a dose of 20 milligrams per kilogram. If the child is not seizing anymore, an IV is not necessarily required, and all hypoglycemic or first-time pediatric seizures should be transported. And for the considerations, it further reiterates monitoring for respiratory depression. It does say that if the seizures terminate by themselves and they have a history of epilepsy, that they may not require treatment or transport. I think if this child's seizure stopped, I would say that given his abnormal vital signs, it would definitely warrant, if the family did not want to transport, it'd warrant online medical control consult, because of this, it sounds to me would be a against medical advice refusal. Seizures may be assigned as cerebral hypoxia from cardiac arrest, and seizures can also be related to dysrhythmias, but this is more typical for adult patients. Anything else to add from anybody?
No, I'd just say,
Go ahead.
I would just say, treating seizures early with midazolam according to your dosing guide, is one of the key interventions that EMS does. There's proven to have benefit, and when we struggle with this, it's more common that we don't treat with midazolam frequently enough. So if there's a question of whether the patient's still seizing, the key is to just to keep up with midazolam until the seizure activity stops, and then be prepared to manage any respiratory depression.
Absolutely. And this particular crew, they did a pretty decent dosing. They're just looks like 7 minutes in between dosing, so the guidelines are 5 minutes, so not bad.
No, and it's hard, and these are busy, tough cases, so it's hard to keep up on that, and I feel like that's the biggest logistical challenge with these patients.
Absolutely. If nobody else has any other questions, I'll move on to case 2. Case 2 is of a 76-year-old male who presented to the fire station. He presented with a complaint of chest pain, only with respirations. This is another case that was referred by one of our paramedics. Actually, this same medic referred this case as the first case. So initially, the patient was alert, his area was open, he was protecting, and they noted that he was cyanotic, particularly from the nipple line up. He was warm, dry, and they noted that he had weak radial pulses that were not symmetric, and there was no signs of active bleeding. Vital signs prior to arrival were documented only to include a blood pressure of 110/60, GCS of 15, and he was estimated to be about 84 kilos. His past medical history was pretty limited or low. The only history that the patient had reported to EMS was that he had a history of high blood pressure and that he was a smoker. He has a prescription for lisinopril, and the history presenting was that the patient was watching, I believe, a football game when he had a sudden onset of chest pain that he described as aching really only with inspiration while he was being driven by his wife to the fire station. He had a witness syncopal episode lasting approximately 15 seconds with a return to mentation, but followed with a lot of vomiting. So the initial vital signs were fire obtained that and they fully included a heart rate of 111, blood pressure 110/60, respiratory rate of 20, and a blood glucose of 170. An IV was established prior to transport crew arrival. A 12 lead was obtained pretty early on, at least what are we looking at? 8 minutes, and another set of vital signs were obtained. They found the patient to be supine on the ground and that, again, cyanotic above the clavicles or just above the nipple line. They noted that his breath sounds were clear to auscultation. He had complained of chest pain with inspiration, but wasn't complaining of shortness of breath. Transport was initiated just over 11 minutes after transporting crew arrival. And another set of vital signs were obtained, still tachycardic, now a little more hypotensive with a blood pressure of 82 by palp. His respiratory rate was 20, and his room air sats were 94% and tidal 29. They documented in their chart that they were having difficulties with getting a automatic blood pressure. So they ended up having to do an auscultated. They did consider aspirin, but they weren't specific for why they did not administer aspirin to the patient. In retrospect, it actually probably was a good thing. And then another set of vital signs were obtained, confirming still tachycardic at 102, still hypotensive at 84 by palp. Respiratory rate is 14, room air sats of 97%, and tidal 29. Because of ongoing hypotension, they administered a liter of IV fluids, and since that did not resolve his hypotension, they started norepi at 4 micrograms per minute. Another set of vital signs were obtained. Unfortunately, no blood pressure was recorded in between that time, but they increased his norepi to 8 micrograms per minute, and they arrived at the hospital shortly thereafter. I did not see a Pulsera to present to you guys. And in reviewing this case, I thought that really great job with early set of vital signs, both for the initial contact and then the transporting agency's arrival. A 12 lead was obtained very early on, which would have met our guidelines for potential chest pain at less than 10 minutes. IV access was obtained. The patient was identified to be hypotensive. Aggressive blood pressure management was initiated in the form of crystalloids and then followed by pressors, and that they had a good index of suspicion. The crews were, from my understanding, both reported but also documented in the chart that they thought that this patient might have a PE given his line of demarcation of cyanosis. They activated the hospital by letting them know that they're concerned about the patient's well-being, and then they were able to document any difficulties they had, including the blood pressure. Only thing I would recommend is, if possible, to use Pulsera, especially if your transport times allow you to notify by Pulsera. Anything else to add, Dr. Mott?
Nothing else for me. I agree.
Okay. So in the follow-up for this patient, he was tachycardic still. His blood pressure was improved to 109/98 when he arrived, and his room air sat was documented as 92%, but there really weren't any discussion about any concern for respiratory distress. In speaking with the physician who took care of this patient, she was worried that he was having an MI. She did get a bedside ultrasound that she performed herself and noted that the patient had quite a large pericardial effusion and that there was evidence of cardiac tamponade physiology on the ultrasound. They placed the patient on defibrillator pads, and shortly after placing him placing pads on this patient, he had a single episode, Brady down, vomited, had a right gaze preference, and then went into PEA arrest. Epinephrine, 1 dose was provided to the patient, 1 milligram, and then at the 2-minute check, he had achieved ROSC. He was intubated following ROSC, and cardiology was consulted because of this pericardial fusion concern for tamponade, which tamponade, cardiogenic shock, and probably contributed to the patient arresting. Because of the patient's presentation, there was concern that there might be a dissection that's leading to the patient's pericardial fusion. So a CAT scan of his chest was obtained to confirm or not confirm that he has a dissection, but also to confirm or not confirm that he had a blood clot in his lungs. The CAT scan actually continued to show a large pericardial fusion, suspicion for hemopericardium, and that he also had a incidental finding of a right upper lobe mass. So I showed some screenshots of the CAT scan to kind of give you guys a better idea of what you're looking at, especially the significance of this pericardial fusion. So this picture here is looking at the heart, and then you're looking at this sliver of grayness, you can think of it, which is concern for pericardial effusion. And then another image also demonstrating the same thing of the amount of fluid surrounding his heart. His troponin came back at 80, and at that point they thought that this was probably demand related given his pericardial fusion. Once it was confirmed that he did not have a dissection, cardiology took him to the cath lab and performed a pericardiocentesis. They placed a drain and immediately evacuated 500 cc's of blood from around his heart. Once the blood was evacuated, he was able to be discontinued off of all pressors shortly afterwards. And he was extubated following the procedure and noted that he was still hypoxic, and he wasn't following commands very well, so they reintubated him. Because of his change in mental status, they did a CAT scan of his head, and unfortunately he had suffered bilateral MCA strokes that were subacute. Family were in discussion about moving forward with palliative care because what they ultimately believe happened was that this patient had lung cancer with metastatic disease to his pericardium, and that he had hemorrhagic conversion that led to the hemopericardium. So he had a poor prognosis for his cancer, and then followed with this bilateral MCA strokes. Also had a very prognosis for the time in between. While his family was trying to determine what their goals of care were, the patient had suffered a PEA arrest, and at that point he was still a full code. So they continued to resuscitate him for approximately 45 minutes prior to calling it with the family's consent. He passed away on hospital day 7. Anything else to add, questions, concerns before going on to pericardial tamponades?
Dr. Gadbois, can you go back to the first blood pressures and stuff by the crews?
Yeah. Can you see that okay?
Yeah. Yeah, that's good. That's it's in areas because the blood pressure, the pressure that you have that's recorded in the hospital is, almost classic for a pericardial tamponade, with the fact that it's, you've got a pulse pressure of 12
Mm-hmm.
or less, or 11, 109 over 98, which is, it's hard to explain anything other than, and of course, this is why the treatment that the crews did initially, which is doing a little fluid challenge, is one of the things that works in the field with pericardial tamponade is overwhelming the venous side, so you at least push more fluid into the heart to be forward pumped.
No, it's
Uh,
uh,
Go ahead.
go ahead. No, I was going to say that's exactly a great point. Good segue into
Yep.
pericardial tamponades. But Dr. Mock?
No, I just wanted to say that the pre-hospital management here was spot on. Just follow the thought process that just recognizing that this isn't looking like ACS, which is far more common, but it isn't looking like ACS. And so, that you got the early 12 lead, the automated blood pressure isn't working. So then getting a palpated blood pressure, giving the fluid challenge, and then when the fluid challenge doesn't change, what you're seeing, then starting on the pressors, just spot on pre-hospital management, and especially the recognition that this looks like something different, whether it's P or something else. Spot on.
Yeah, no, definitely. And the medic that brought this up to me wanted to know if this patient had a PE because of the physical exam findings, and wasn't aware of this condition, that the patient ultimately had this condition, and we talked about it afterwards. Pretty amazing, especially since we don't typically see hemopericardiums from medical induced causes. Usually that's trauma. So thank you guys for your contributions and your points. So I just wanted to spend a moment talking about pericardial tamponades. That's when excessive fluid accumulates within the pericardial sac. This inhibits the heart to relax and to fill. So that decrease in the filling of the ventricles and the atrium as well leads to impaired cardiac output or flow out of the heart based off of not being able to fill appropriately. There are three types of fluid that can accumulate. They can be purulent, they can be so like exudative, they can be transudate, and they can also be blood. The onset of the pericardial tamponade is going to be a major determinant on how the patient's going to do. If the blood accumulates rapidly, then the heart can't, I would say, the heart can't function or compensate for that rapid accumulation. So the patients tend to be pretty symptomatic with less amount of blood and, or not blood, a less amount of fluid. As for patients that have a slower accumulation, they can compensate and potentially have a larger amount of pericardial effusion before they become symptomatic. So this patient had a sudden onset of what they suspect of hemopericardium and a significant amount of accumulation of 500 cc's. So this patient understandably did not do well because of the rapid onset of his pericardial effusion and the size of it. I was going to say something else about this too. Yeah, so some ideas of when a patient might have slow accumulation of pericardial effusion are patients that are on dialysis. They maybe have a uremic induced pericardial effusion. And then also patients that have a history of heart failure, they may also develop a pericardial effusion. And then another example of a patient that might develop a slow pericardial effusion are patients with cancer history. They believe this patient, as mentioned earlier, had a sudden onset despite the undiagnosed pulmonary cancer. So when fluid accumulates within the potential space of the pericardial sac, it decreases the ability for the heart to fill during the diastolic period, which impairs the stroke volume. The heart rate may actually, most likely, they'll become more tachycardic, but they won't have the stroke volume, so their cardiac output will decline. The patients with this condition will usually present in shock, either obstructive or cardiogenic kind of a presentation. So hypotensive, tachycardic, without signs of bleeding, without spinal injury or suspected spinal injury, without anaphylaxis. You may see elevated jugular venous distension. And then there's some physical exam findings I'll talk about that might help cue you in, but this is a clinical diagnosis that even when we have an ultrasound to confirm if there's fluid is also based off of the pericardial tamponade is based off of not just the physical exam finding by ultrasound or physical exam finding suspicious for this. It's also the patient's vital signs and how they're doing that are combined in determining if we're dealing with a pericardial tamponade. So the patient might complain of chest pain, they might complain of shortness of breath, they might get lightheaded or have a syncopal episode because of impaired perfusion. They may be altered, and then these patients may go into cardiac arrest, and most likely to be a PEA arrest. Why we talk about H's and T's to include tamponade with the T's. Physical exam findings that might cue you in on this condition includes Beck's triads. So that would be hypotension, muffled heart sounds if you were listening for heart sounds, and jugular venous distension. The patient may also have a condition that we refer to as called pulsus paradoxus, when the systolic blood pressure drops at least 10 millimeters of mercury with inspiration due to impaired blood flow return to the heart because of the increased intrathoracic pressure. And then as for diagnostics that can help you with this diagnosis, 12 lead may show you some findings. Sometimes you may have heard of low amplitude EKGs where both QRS and the P waves are small. You may also have heard of pulsus alternans, where one QRS is larger, the next one's smaller, the next one's larger, but more likely you're actually going to see tachycardia. And when you have this condition, then you are necessarily going to be able to see low amplitude or pulsus paradoxus or electrical alternans. I apologize, electrical alternans on your EKG. So tachycardia should be one of your first things to be looking for. If the patient's at the hospital, we can get a chest x-ray and see if the heart appears to be enlarged in the cardiac silhouette. And then when we have the ability to use cardiac ultrasound, that'll help also confirm this condition, and also gives us an idea if we're seeing tamponade physiology. Tamponade physiology in regards to ultrasound has to do with bowing of the septum, and that implying that it's impeding the filling of the heart because of the increased pressures exerted on the heart from the pericardial fluid. Management of this includes IV or oxygen administration, IV access, and IV fluid resuscitation. Up to a liter from what I could find, but you can start with 500 cc's and consider to re-administer if the patient could tolerate it. They really recommend that the patient doesn't exert themselves. The patient should be supine. You shouldn't be having them walk up or down stairs. Really minimal activity because of the fact that this could further exacerbate their cardiac output, leading to cardiac arrest, and that the definitive treatment for this patient with this condition would be pericardiocentesis with drainage from the pericardial potential space. And then in some circumstances, like in this one, putting in a drain so that they can continue to drain any accumulation that occurs after the initial procedure. And if this condition is suspected, we highly recommend avoiding positive pressure ventilation. So unless it's absolutely necessary, such as like in cardiac arrest, but trying to decrease the increased intrathoracic pressure that would further increase the impaired cardiac output. Anybody else want to add anything here, or are we okay?
And I think clinically, we most often see this in someone who has a chest cancer, so either lung cancer or breast cancer. Rarely we've seen it in people who recently had a viral illness and then have a pericarditis. and then develop fluid. But clearly, it's most often in cancer that it seems to show up.
Yeah, and that's a good point too. Like autoimmune disorders too can also lead to pericardial effusions, like lupus. So for our protocols, I brought up syncope and shock. An example of where we might think syncope is not that big of a deal, but another great example that there's a lot of pathology that we're not necessarily privy to in the pre-hospital setting. So high index of suspicion to be suspected. So syncope, we know, is loss of consciousness that can be related to postural tone, and that it resolves spontaneously without intervention. A patient may refer to it as fainting or falling out. Typically, this is abrupt and resolves quickly. They may actually be pretty much asymptomatic upon our arrival. And then pre-syncope is the prodromal symptoms of syncope, such as lightheadedness or nearly blacking out. Our recommendations are to identify the underlying cause of syncope whenever possible. So doing a good neuro exam, doing a good altered mental status differential, and doing our basic universal patient care protocol. We should be looking for abnormalities in the physical exam or in the EKGs, as well as vital signs, and then managing airway, oxygenation, controlling hemorrhage if there's any present, getting IV access, administering IV fluids if the patient's hypotensive, and then continuing to monitor them for any cardiac changes. And then under the notes and cautions, all patients suffering from syncope deserve hospital level evaluation, even if they appear normal with few complaints on scene. So that's a good reminder that we should really be recommending all syncope to be coming to the hospital. I would say that really being cautious about even near syncope, as that might be early signs of a pretty significant pathology. And then the next part of the protocol that I think it was appropriate for this patient is shock, specifically the cardiogenic shock section here under D as in David. So you're looking for any rhythm changes or rhythm abnormalities. You try IV fluid bolus in the form of 250 or 500 cc's to see if the patient's blood pressure responds with a systolic above 100. If it doesn't, you can repeat this unless that there are signs of volume overload, in that you're aiming for a max of 1 liter. If the patient's blood pressure does not improve, then we recommend norepi at dosing of 4 micrograms per minute. That can be administered IV or IO, and that can be reevaluated every 5 minutes to increase in increments of 4 micrograms per minute up to 12 micrograms. If this is not effective, epinephrine can also be administered. Anybody else for case 2? All right. Moving on to case 3. This is a case of a 69-year-old patient who, I believe, yeah, I did write it, that initially fire was dispatched for a public assist. Once they, or at least from their documentation, that once they identified that through dispatch that the patient was unconscious, they requested additional assistance or additional resources. When they found the patient, he was unresponsive. His airway was open, but he wasn't protecting it, and he was actually pulseless, no signs of bleeding. Initial vital signs, heart rate 0, no blood pressure, no respiratory effort, and the patient's past medical history was documented as cancer, reactive airway disease, and diabetes. His medications included albuterol and olanzapine. And according to the documentation narrative, this was a witnessed syncopal episode for the patient by his wife. He had a history of throat cancer. There's no DNR for the patient, and that she initiated CPR prior to EMS arrival. The complicating factor, too, was that she was deaf And from at least some of the documentation from the transporting agency, she had to call her daughter to call 911, I believe. So this occurred, or at least patient contact was at 2:49 in the afternoon. Noted to have a heart rate, at least electrically, of 130, so PEA, SATs of 92%, and Title 40. CPR was initiated, and it's documented that the patient was bagged successfully, is what is documented. Shortly thereafter, the patient was identified to be in ventricular fibrillation and was shocked at 200 joules. After shocking the patient, iGel was attempted to be placed, but that was unsuccessful. The patient had an IV established, and a few minutes later, it was documented that the patient was bagged through the stoma for him, and it was also documented as videolaryngoscopy, but I think that's a documentation issue, as this would not be videolaryngoscopy, but a cuffed Shiley was placed in the stoma successfully. At this point, the patient receives his first milligram of epi, and he is being bagged through the Shiley, through the stoma. The patient had what they believe was torsades. They shocked him at 300 joules, and following the shock, the patient did achieve ROSC. A few minutes later, 12 lead was obtained. I don't know if this is the same 12 lead from the initial ROSC, but this is the one that was in Pulsera. This showed AFib with RVR. He was noted to be tachycardic at 146, blood pressure of 152/130, a respiratory rate of 14, SATs of 75%, despite Shiley bagging, and Title 35. Transport was initiated approximately 7 minutes after ROSC was achieved, and another set of vital signs were obtained. Still tachycardic at a rate of 148, blood pressure 137/62, respiratory rate of 13. Now his SATs are at 100%, and Title 26. They arrived to the hospital at 15:22, and after they arrived, it looks like they gave the patient 100 micrograms of fentanyl because of spontaneous movement and now breathing on his own. It's documented from the hospital side that the patient had magnesium prepped but was not administered, so I just added it in this section here, as it wasn't in our narrative, but it's worth mentioning. So under Pulsera, the patient was notified to be a red. The narrative for Pulsera showed that it was a cardiac arrest in VFib and torsades. Second shock converted the patient to a narrow complex at a rate of 170. I believe that this is supposed to say stoma, not vent dependent. EMS placed Shiley, history of throat cancer, and just started chemo. Heart rate was 100. It stated that he was being bagged, and his SpO2 was 100 with his end tidal of 28 and a blood pressure of 137/62. In reviewing this case, I thought that they did a great job, and I think that I'm really just echoing a lot of what I saw Dr. Mock had already mentioned, but requesting additional resources early on when they suspected that this might be a patient that's not a simple lift assist or a public assist. Rapid initiation of ACLS, especially since this wasn't pre-dispatch notified that this patient was in cardiac arrest. Initiating CPR, defibrillating the patient, getting a 12 lead. Thought the Pulsera report was appropriate, and the teamwork when met with a barrier, both with the patient's wife being hearing impaired, and then also with the difficulties with ventilating this patient. We identified that there was some areas for improvement, which would include airway management with a patient with a history of a stoma and throat cancer, as well as just kind of reviewing it myself. Medication administration for VFib. If early on, amiodarone could have been an option, but once torsades was suspected, maybe magnesium administered anyway would have been a better, and then getting a blood glucose for rounding everything out. Is there anything else that Dr. Whitwer or Dr. Mock would like to add?
No, I think that's spot on, and I agree. If the magnesium was drawn up, I certainly would have given it at that point, even if you've now gotten atrial fibrillation. I mean, he's already proven that he could go into torsades, so you might as well correct some of his QT prolongation.
Yeah, that's a good point.
I disagree. It's just a really good pivot where you're not getting the dispatch information. You're walking into a really difficult scene, no, I think that's. I agree with everything you said.
Yeah,
Awesome,
I think
thank you.
I think this is a really good case. It was. I mean, I really can't fault anybody at the scene. They did an excellent job.
Absolutely. So in the emergency room, history actually was that the patient has a history of squamous cell carcinoma of the larynx, and he had a total laryngectomy done approximately a year earlier with a left hemithyrectomy, thyrectomy, and bilateral neck dissections maybe 6 months prior to this incident. And that the family arrived confirming this history, and that he recently had a recurrence of his cancer, and he recently initiated chemo. His vital signs when he arrived was 36.4 Celsius, heart rate of 154, AFib with RBR, blood pressure 108/77, respiratory rate of 18, and SATs of 98% being bagged through his Shiley. In addition to the AFib with RBR, his QTC was noted to be 552. Cardiology was consulted due to concerns at this. They said that his EKG didn't look like he met the Scarbosa criteria, but wanted to make sure, given the fact that the patient was a cardiac arrest, that they wouldn't want to activate the cath lab. Cardiology agreed they would not activate the cath lab, and they also recommended no heparin. As a side note. Anyways, the patient had a central line placed for cooling since he was not responsive, and his labs were notable only for an elevated troponin, which I thought initially was related to his cardiac arrest and getting CPR. And then his pH was a little bit low at 7.2, which would be not too unexpected given his cardiac arrest. They did do a CAT scan of his head and a CAT scan of his chest, which was only notable for sternal and rib fractures, where he had rib fractures 2, 4, and 6 bilaterally, which they attribute to CPR. The emergency room documented that they went ahead and administered the 2 grams of magnesium. They had documented also that they didn't have any tracings to confirm it, but going off of the interpretation, treating for torsades, and he was admitted to the ICU. While in the ICU, he had an echocardiogram that showed a reduced ejection fraction to 25%. They managed that just medically. And because of ongoing elevated troponins, they cathed him, and he ended up having pretty significant disease where they had 3 stents placed. The patient had a question to having pneumonia, but given his cancer history and some other points, they were reluctant to manage that too aggressively. So ultimately, the patient decided he was going to leave against medical advice, and they did not initiate antibiotics. One of the fire responses for this case had said that this following day, they had a call to this patient again, and he was complaining of shortness of breath, concern for pneumonia. So he may be on antibiotics now or completing his course. So this case was brought to you guys based off of a laryngectomy and how to manage the airway with a laryngectomy. The good news is that laryngectomies are uncommon. We'll see more tracheostomies than we'll see laryngectomies, but The image here on the left-hand side shows you normal anatomy, blue representing air, I guess. So with a normal anatomy, you get air from the nose, you get it from the oral pharynx, and then it comes down through the larynx into the trachea. With a tracheostomy, you now have a entrance from the neck that is another source for where airflow can occur. So still nose, nasopharyngeal, oropharyngeal, and now through your tracheostomy stoma. Laryngectomy is that you no longer have airflow coming from the nasopharynx or the oropharynx, and that is actually deviated to only come through the stoma and the neck. So there's no ventilation possible from either nasal or oral down into the trachea, and that any efforts would be futile if you weren't using the stoma. So preferably, we would use a Shiley when we have a patient that we know has a laryngectomy or suspected laryngectomy, or they have a stoma. That probably be best to just go ahead and ventilate through the stoma and not trying to figure out if this is a tracheostomy or a laryngectomy. Shiley would be preferred. That might be something that you don't actually have access to in your kit, and you have to go back to your engine or to your ambulance. So in the interim, you can use an ET tube that's cut down. The feedback we got was that could we go over how to administer or how to replace the Shiley? So that's what I'll do with you guys.
The flange on the side. Do not touch the trach body, the part that goes into the airway. If your trach tube has a cuff or balloon, you'll need to test its integrity first. Load your syringe with air and attach it to the pilot balloon. Slowly inflate the balloon, making sure there are no ruptures or tears. Deflate the balloon before you disconnect the syringe. Most people will not require an inflatable trach tube cuff, but those on a ventilator or who have an impaired airway may need to have their tracheostomy cuff inflated. Open the water-soluble lubricant. Again,
I will say that this is ideal situation. Obviously, we don't have the patience, the lighting, all the equipment necessary to do this ideally. So as you watch this video, familiarize yourself with what's available to you. I think the points that I would say is try to be as sterile as possible and to not forget to check your equipment. So continue to play this.
and if you don't have lubricant, you can always use distilled water. Do not use tap water. Apply a generous amount of lubricant to the trach tube body.
I think lubricant would definitely be in order if you have it to help place it into the stoma, but you can also use just the patient's secretions or
do not use this
phlegm,
tie.
I guess.
Craig recommends using a Velcro tie.
Craig is the hospital that this video comes
Next,
from.
Remove the trach tube obturator from the package. This is what you'll use to insert the new trach into the person.
A good point to remember here.
Insert the obturator into the trach tube. Note that there's a rounded tip for easier insertion. Now prepare the person. Place a clean towel or chucks on the person's chest. Gently remove the old trach tie. Keep gentle pressure on the tracheostomy tube while removing the tracheostomy tie. Slide the tie out from under the person. Install the new Velcro tracheostomy tie, keeping pressure on the tracheostomy tube. The tie will come with instructions that tells you which side goes against the person's skin. Slide the new tie under the person with the correct side touching the skin. Now, you're ready to remove the old tube and insert the new one. It's important to have the shortest amount of time possible during this process. Hold the new tube with your fingers on the flange and your thumb on the obturator. As you get ready to remove the old tube, ask the person to take in a deep breath. This dilates the airway. As they are taking in a deep breath, remove the old tube. Ask the person to take another deep breath to dilate the airway. As they are taking a deep breath, insert the new tube. Be sure to remove the obturator. Keep the obturator in a safe place in case you need to use it again. Now,
that is a good point. In the event that you need to reposition or replace it, you want to know where the obturator is until you confirm that you're able to ventilate, and you have to take the obturator out to be able to attach the bag valve mask adapter.
now attach the new trach tie to the new tube. Make sure it's not too tight, but snug enough to keep the trach tube in place. You should be able to put 2 fingers in between the trach tie and the person's neck for proper tension. Place a clean split drain gauze.
All right, I think that is probably more than you guys need to know about replacing or placing a Shiley in a stoma. So the parts of the protocol that I added here were VFib and pulseless VTAC. As a reminder that we're going to be defibrillating them as soon as it's identified, to continue doing CPR for 2 minutes and then reassessing the rhythm, defibrillating if it's indicated, and then following with 2 minutes of CPR. Administration of medications, that would be likely amiodarone, unless there's a contraindication such as torsades, then lidocaine would be appropriate. Actually, more appropriate than lidocaine would be magnesium for torsades, and if there's a contraindication of giving amiodarone, lidocaine would be your option. You're going to reassess the heart rhythm, defibrillate if there's an indication such as VFib, VTAC, resume 2 minutes of CPR. At that point, your option would include epinephrine. In the notes and precautions, if there's a delay in getting IV access that is leading to your third shock and you haven't given meds, you can give epi and amiodarone together if the patient doesn't have any contraindications, amiodarone. Assess them a 4th time if they have a shockable rhythm. You want to change the vectors of your defibrillation pads, either AP or AA. I forgot what the second A is, but can anybody else on this call remind me what the second A is as opposed to anterior? Anyways, for your 4th shock, if it's unsuccessful, continue CPR. You can give another dose of amiodarone at a reduced amount at 150, and if amiodarone is not indicated, then lidocaine. If at that point your rhythm is still VFib, VTAC, do 2 minutes of CPR, defibrillate, do 2 minutes of CPR, get another dose of epi. Continue this until ROSC is achieved or death in the field criteria is met. And then if ROSC, we're really targeting for SATs of 94 to 96% and end tidal of 30 to 40. I think that's your major stuff here. Making sure in the notes and precautions that we're really managing the airway without interruptions. And that our breaths should be 8 to 10 per minute. If the patient has received 4 shocks and they're still in a shockable rhythm, changing pad placement. Bicarb should not be a go-to unless there's an indication either for a prolonged downtime, tricyclic, or suspected hyperkalemic. And yeah, those are the major things. Anybody you want to add anything for case 3?
No, I think that's an editing error. So you switch from anterior posterior to anterior lateral or vice versa.
Yeah.
And then no, I think the key point here, and I agree with everything that you said about the Shiley. If you don't have that available, first thing you can do, as this crew did, is bag over the stoma, but then just think about it like a crike where someone's already made the hole for you. And you just put the tube in there, ventilate through the tube.
Exactly. So almost all of them, everybody should have a Shiley on board because they're prepared to do a crike. So this saves you having to pick up a knife.
Are Shiley's part of the kit, the come in kit or the take in kit?
Mhm.
There. Oh, okay.
They should, for their cricothyrotomy kits, they all should have Shiley's.
I'm just saying that is that part of the kit that they bring into the scene, or is that just? That's what I'm asking, because this
Yeah.
particular crew had to go back out to get it. So I guess what I would say is if it's not part of your normal take-in kit, to communicate that to the other department coming in to make sure to bring that in, so that we try to limit the amount of back and forth if possible.
Yeah, good point. And actually the QTC, I noticed on the QTC was quite prolonged, so that's another good reason that they in the ED gave magnesium. They didn't have to prove that they had torsades.
Yeah, I think that really Mark was the reason why I put the QTC in there, because they didn't document that in their charts, either the H&P or in the discharge.
Mm-hmm.
So thanks, Mark, for putting that in. So case 4. Thank you guys for your attention. This is the last case. I think it's pretty quick-ish. So this is a case of a 77-year-old who EMS was called for weakness. The patient was awake. His airway was open. He was protecting it. Notably, he was pale, cool, diaphoretic, and there were weak distal pulses. His heart rate was 63. His blood pressure was 131/71. Respiratory rate of 18, SATs of 94%, and blood glucose was documented as 215. Past medical history included high blood pressure, high cholesterol, and GERD. He was prescribed atorvastatin and famotidine, and the history of the present illness was that he's been sick for the last 5 days with a cough and nasal congestion. The patient is the patient I had taken care of, so the additional information that wasn't listed, probably just because he didn't provide it, was that he was traveling back from the East Coast for the holidays, and did mention that he had sat at an airport for a prolonged period of time, probably where he was exposed to a viral illness. He's been anorexic for the 2 days subsequent to or prior to his initiation of 911, and that the day of illness that he called for help, he was complaining of nausea, vomiting, and dizziness. He said that he felt weak all over, and that EMS had documented that he wasn't even able to walk in his own home where he lives independently, that he was crawling on the ground to get from space to space. So those vital signs I already presented to you guys. So my understanding, it's not quite specific here, but at 15:44, I believe this is when they sat him up from the bed to get him over to a chair. He braided down and had a syncopal episode. This was and returned to mentation shortly after. EMS got a 12 lead at that point, so early on again. Noted to still be bradycardic at a rate of 40 and now hypotensive at 88 by palp. An IV was attempted, unsuccessful. Another 12 lead was obtained, and a third 12 lead was obtained, noted to not be as bradycardic at a rate of 67. Finally, an IV was able to be obtained, and another set of vital signs, heart rate now back to 80, blood pressure 119/61, and temp was documented as 95.1. Transport was initiated at 16:18, and he was noted to be kind of borderline in hypotension now with a blood pressure of 98 by palp, heart rate of 83, room air stats of 93%. A second IV was established, and a fourth 12 lead was obtained. So really aggressive and appropriate management for this patient. They notified us that the patient was coming in as a red, and they put in the narrative that he was sick since Saturday. He had syncope when he stood up. He had lost his radial pulses when he syncopated, and that the vital signs they recorded were largely normal besides a temperature of 95.1. The charge nurse came up to me and asked me, I think that these guys put this in incorrectly, that it wasn't supposed to be red. luckily and thankfully, this crew responded immediately to our request that, is this patient supposed to be a red or was this an accident? And they had said, nope, red. That's all we needed to do to confirm that we would meet this crew with appropriate reception. So in reviewing this case, I thought that the index of suspicion was really quite good. When the crew arrived, they had apologized, which really wasn't necessary, but they had said that they were worried that the patient was septic. And although we didn't meet the criteria for our protocol, they still wanted him to have eyes laid on him and this resuscitation initiated early. They did many 12 leads for this patient and did many vital signs. And they notified the hospital early on, especially in the current state that we are in, where we have a lot of patients waiting in triage, and especially when we potentially put EMS patients out in triage. It's really important that your guys' eyes and your concerns are relayed so that we can try to get patients to the appropriate location, especially since our wait times can be quite long. The only thing that I would say for areas for improvement is that in the Pulsera, they documented pretty normal vital signs. I think that bradycardic rate and that blood pressure would have been helpful, would have been nice, but I think just calling it red and confirming that is okay as well. And the only other aspect I would consider is doing an end tidal CO2. Technically, the patient did meet sepsis criteria, but the end tidal could have led to meeting sepsis criteria. So when you go ahead.
Dr. Gadboy, two things. I know that they established 2 IVs, but what were the total amounts of fluid given?
I didn't write it. It's possible that I didn't document, but usually I put in parentheses how much fluid was given, although I am 16 hours ahead of you guys right now, and my mind is not necessarily thinking right.
Well, that's okay.
I believe from my own recollection it was like 400 cc's.
Yeah,
from the handoff report that I received.
So my point on that is it's a little bit like a trauma case, in that we want them to record and to send in the Pulsera the initial and worst set of vitals that they have, because then you wouldn't have had any question whether this is a red patient or not.
Yeah,
it would have been nice to put in.
Extrapolate. Yeah, we could extrapolate from that last rate of pulse, but it definitely doesn't lead to any misinterpretation if we have that information in there.
Exactly. And it's like, with, in trauma, we say that someone who starts out with as hypotensive, but then the next set of vitals are improved, they're a responder to your treatment, to your resuscitation. And that's valuable information too, but it's always good to get what they based their red on, which was bad vitals and a suspicion that this was a sepsis.
Mm-hmm. That's a good point.
They were spot on. I mean, there's.
Oh, agree. And that brief sentence in Pulsara communicates a ton.
Yep.
It does. It doesn't, to be honest, I know this doesn't come as any surprises. All of our charge nurses are not the same caliber. And this particular charge nurse was more involved in that, coming to check with the doc to make sure that there wasn't any questions. It doesn't make sense where some of our charge nurses are pretty new or just kind of robotic in that they would say, well, this looks okay, maybe ideally that shouldn't happen, that they would downgrade a red to any other condition other than red. But sometimes I understand that might still happen. And the other thing is that they may not take it as seriously just because they look at it and say, this doesn't make any sense, I'm just going to room this patient or put this patient out in triage. So, is there anything else, Dr. Mock?
Nothing else for me, no.
Okay. So once the patient arrived to the emergency room, his rectal temperature was 34.7. He had a normal heart rate of 91, blood pressure 114/84. Respiratory rate, though, at this time was 31, and his room air sat was 98%. I will say that he looked ill in that he just kind of looked deconditioned, worn down, bags under his eyes, and his skin was mottled, which was suspicious for perfusion problems, and cold to touch. He was placed in a bear hugger, and although we activated him as a sepsis alert based off of his temperature and his respiratory rate, we took 2 hours to get labs on him because although we could get lines in him, he was so so dehydrated that once the line was placed and we attempted to suck blood from our vacutainers or from our syringes, it completely collapsed his vasculature. So it was markedly difficult to get any labs from him. Um, Even the central line placement after like the 15th stick was also an issue, and that it wasn't until we were able to further rehydrate him that we were able to get a central line 3 to 4 hours later on this patient. His labs were notable for influenza A. He also had a mild acute kidney injury with a creatinine of 1.6, just for the people that know those values, but also for the docs on the call. And his potassium was 6.6, so it was elevated. His hemoglobin and hematocrit were elevated, but in the context of what was going on, I suspected that he was really, really dehydrated, and that the values for his blood lines were really just based off of very little plasma. During his ED stay, he did develop hypoxia, up to 6 liters nasal cannula to normalize his SATs, but his CAT scan of his chest looking for a PE was negative. His CAT scan of his head was obtained because he, as you know, as not to be surprising, had told us or told me that he actually syncopated before EMS arrived and smacked his head. There was no signs of bleeding in his CAT scan of his head, in that both the CAT scan of his head and the CAT scan of his chest, the radiologist documented signs of pretty profound hemo concentration and dehydration with a flat IVC, inferior vena cava, and that the vasculature in his brain was also consistent with profound dehydration. The patient was initially responsive to IV fluids, but after 6 or 7 hours waiting in the emergency room for a bed, he became more and more hypotensive and refractory to IV fluids. So norepi was administered, and he was switched from the floor bed to an ICU bed. The following morning, because he came in the afternoon, if I remember correctly, 15:39. So the following morning at 7 a.m., he was found to be hypoxic, and he suffered a PEA arrest. He was intubated, and ROSC was achieved within a couple rounds, and that it was maintained. His ROSC was maintained on 3 pressors. He was substantially volume overloaded despite his dehydration, initially with reports of 27 liters up, and that he was in renal failure despite his IV fluid rehydration. So he ended up needing continual renal replacement for a few days. He was extubated. I think he came in on like the 3rd, but anyways, let's say he got extubated on hospital day 6, and that he was getting intermittent hemodialysis runs by hospital day 8. Unfortunately, I do not have Epic access, but it sounds like from what I last reviewed on this patient that he finally made it out of the ICU, was pretty groggy, but looked pretty promising that he was going to be able to be discharged from the hospital. So pretty miraculous course of a flu. So thought I'd take a moment to talk about flu, as all of us are seeing a lot of flu, and we're asking at both our hospitals that patients and providers come in masked. So this is a viral illness affecting the upper and lower respiratory tract. There are 4 viral types, A, B, C, and D, and A and B affect humans. Seasonality, this occurs yearly around autumn and winter, or both autumn and winter. And transmission is based off of respiratory droplets or contact with respiratory droplets that someone touches and then uses their hands to touch their eyes or their nose. Patients can be communicable prior to them even developing symptoms and up to 7 days after symptoms. And usually the signs and symptoms that the patient might suffer would be like runny nose, cough, sore throat, fever, specifically to the virus. And then based off of the immune response, they might also complain of myalgias. Mortality is highest among pregnant patients, patients with underlying cardiac disease or pulmonary disease, and then, of course, extremes of ages, very young, very old. Please wear a mask. This case, though, I didn't bring up because I want to talk to you about influenza. I brought up because I thought that this was a really profound case that EMS really helped facilitate getting eyes on this patient and helped them, even though this patient ended up going into cardiac arrest. I think that we would have seen this patient much sicker if the patient might have squeezed into triage or was a green patient that came and got roomed and didn't get seen right away, or there wasn't as much of a worry. So really big kudos to the crew. And from my understanding, both crews, fire and AMR. So our protocols for sepsis, like I mentioned, this patient wouldn't technically meet it from my my review of this. So SATs above 95 as our goal, and then known or suspected infection with 2 or more of the following. The patient was not febrile, although he did have a low temperature. His respiratory rate was documented to be within normal limits, so respiratory rate greater than 20, heart rate greater than 100, end tidal less than 25. And if 2 or more of the section C that I just mentioned are present, then blood pressure of less than 100, systolic with a MAP of 65, or altered mental status would also trigger for septic shock alert notification to the hospital. Resuscitation of these septic patients includes 2 liters of IV fluids, preferably lactated ringers, and you want to maintain a MAP of greater than 65. You want to ensure that your neck veins are not becoming distended, because then we would potentially slow down or stop our fluids, and that there are no evidence of pulmonary RALs. If the patient is not responding to the IV fluids, such as their blood pressure is low or their MAP is not optimal, then norepi at 4 mics per minute could be administered, increasing every 5 minutes by increments of 4, stopping at 12 micrograms per minute. And then you can also use epi. Okay. Anybody have anything else to say about case 4?
I completely agree with everything you said. I just let people know I'm also aware of a patient that was at Salmon Creek, otherwise healthy patient in the 50s whose only risk factor for severe influenza was not being vaccinated for influenza, who died in the past month. So it's about 1 in 1,000 patients with influenza that'll get quite ill. But no, I agree with everything you said, and I think it was great recognition of a sick patient on the part of this crew.
Absolutely. Thank you. And it's unfortunate for your guys' patient too. So in summary, pediatric seizures could be febrile, could be other causes, and could be something more than just epilepsy. So we have a patient with pyridoxine-related epilepsy in our county. The image on the far bottom left is a line of demarcation for that pericardial tamponade patient. From what I could find, their superior vena cava syndrome, pulmonary embolism, pericardial tamponades can give you this, so it's not pathognomonic for one condition. Think of it as something that's impairing cardiac output, and that could be any of those 3 or other conditions. But recognizing that a patient is sick with shock and potentially obstructive shock is huge. Picture on the on the upper right is a patient with a laryngectomy after neck dissection. You can see the staples. These patients should not be ventilated from their mouth or their nose. They should be ventilated through their stoma. Although this is a rare condition of having a laryngectomy, you probably are best suited by starting at the stoma to ventilate the patient. And then lastly was decision making. Lots of cogs go into making those decisions. Balancing between your own expertise and your physical exam findings, your differential diagnosis, and appropriateness for care. So we recognize that you have a lot of wheels going to identify and get the patients the care that they need at the right place. So thank you for doing your job, doing that job, and doing it so well. Any questions while I'm here in Taiwan at 2:00 in the morning?
No, just say thank you and thank you very much for doing this far off your circadian rhythm.
Oh yeah, absolutely. All right. Well, thank you guys. Have a good night.
Maybe you should get some sleep now.
I'm going to. My housemates would like me to stop talking.
Enjoy the rest of your vacation for sure.
Thank you. You guys have a great day. Take care.
Thanks.
Bye.